So HIV and AIDS. HIV, that is the human immunodeficiency virus, which is cause AIDS, acquired immunodeficiency syndrome, and it was first reported in June 5th, 1981, in Los Angeles in 5 homosexual men. So first it was identified or reported in June 5th, 1981. Mainly, it was identified among the 5 homosexual men. So homosexual, that is sex, men sex with men. So there are different terminology, that is MSM, men sex with men, lesbian, girls, heterosexual, opposite sex, homosexual, same sex. So there are the terminology. So first it was identified in 1981, June 5th. Then after 2 years, in 1983, Dr. Luke Montagnier named LAV, that is lymphadenopathy associated virus, LAV. So in 1981, it was identified or reported, and after 2 years, in 1983, Dr. Luke Montagnier named lymphadenopathy associated virus, that is LAV. Then after 1 year, Dr. Robert Gallo confirmed that is STLV, human T cell lymphotropic virus THAR, in 1984. And in May 1986, International Committee on Taxonomy gave a new name called Human Immune Deficiency Virus, HIV virus, in 1986. And this is a short history regarding HIV and AIDS. 1981, first case detected in USA. In 1983, that is after 2 years, virus identified. In 1984, first time HIV case detection in Thailand. So after 3 years, first case detected in Thailand. Then 1986, first time case detection in India. In 1986, first time case detection in India. And 1987, after 1 year, first antiretroviral introduced worldwide. And in 1988, so after occurrence of the 2 years in India, so after 1986, in 1986, first case detection in India, and after 2 years in 1988, first time case detection in Nepal. In that period, there were 2 men and 1 commercial girl. At that time, 2 men and 1 commercial woman or girl had occurred at first time. And in 2003, first antiretroviral, that is Gidobudin, was introduced in Nepal. So this is the short history of HIV and AIDS. So what happens after HIV infection? So incubation period is very long. It may be 6 months or it may be as long as 10 years. So incubation period is very varying. It depends upon the immune system, malnutrition, and other condition. And according to WHO, the median period of developing AIDS is 9.2 years. So it may be range from 6 months, shortest period, and the longest period 10 years. But according to WHO, median period is 9.2 years. So mainly it affects the helper T cell, CD4 cell. It destroys the CD4 cell or suppress the CD4 cell. It is RNA virus, but our cell is DNA, and it convert that RNA virus convert like is DNA. When the cell multiplication, again that RNA virus also multiply in the body. Then the number of virus is high, but our CD4 cell, helper T cell, is low. That's why, or due to that reason, there is destroys immune system, because HIV destroys the natural defense mechanism of the body, and the body is prone for opportunistic infection. So there are many opportunistic infection. In short form, we can say OIs. So among them, tuberculosis is the top risk factor or disease on OI's list. Tuberculosis is a top one risk factor or disease in opportunistic infection. Okay, epidemiological determinants. First, agent. Agent is human immunodeficiency virus, HIV virus. It is an RNA virus and a group of retrovirus. And there are two types of HIV, type 1 and type 2. Type 1 is more common and more virulent than type 2. Type 2 generally occurs in or it is prevalent in African region, but type 1 is universal or it is the most common and it is more pathogenic than other. The virus is about 1 to 10th okay, 10,000 of a millimeter of the diameter. So it is a 10,000 to one part of the 10,000 of the millimeter in the diameter. So it is very small. So it is a microorganism and easily killed by heat, inactivated by ether, acetone, ethanol, and the destroyed human T4 helper cell. That is, it mainly affects the T helper cell, right? The CD4 cell, which is associated with antibody production. So it mainly destroys the T4 helper cell, CD4 cell. In advanced stage, there is very low number of the CD4 cell, even less than 200, even 100, even 50, less than 50. But generally 500 to 1500. That is normal for CD4 cell. But in advanced stage, there is suppression of the CD4 cell and there is leukopenia and can survive for more than 10 minutes in open air. Okay, reservoir. So man is only reservoir and the principal source of infection because there is no chance of transmission from animal to man. There is no chance of transmission to from mosquito to man, leech to man. So man is the principal reservoir. It may be cases or it may be carrier because the person can transmit the disease even the person is symptomless. That is in window period. Generally, window period consists of 3 to 4 weeks. So during this time, there is no sign and symptom, there is no antibody detection, but the person can transmit the disease. So that is very risky. So that is window period, which consists of 3 to 4 weeks. In this time, there is seroconversion is not positive, or the HIV test is negative in that period. So that is called window period. In window period, the person can transmit the disease. And once person is infected, virus remains lifelong. So reservoir cases either sign and symptom present, clinical manifestation. There are mainly different classifications are there, but there are major classification and minor classification. In major classification, there is fever more than 1 month, diarrhea more than 1 month, weight loss more than 10%. So they are the major classification or major clinical manifestation. Either there is presence of these sign and symptom or symptomless. There is no clinical manifestation. So in both cases, the person can transmit the disease. Source of infection, mainly there are four sources of infection. That is blood, mainly blood, then semen, vaginal fluid, and breast milk. So these are shown to transmit the disease. So conclusively shown to transmit the disease by blood, semen, vaginal fluid, and the breast milk. And the virus is also found in tear, saliva, urine, cervical, and obviously cervical beta, then CSF also. But from other sources, it is not transmitted, but it is transmitted only blood, semen, vaginal fluid, breast milk. So they are the four source of infection. From other, although there is presence of virus, but that is not transmitted. From this route or this source, the disease is only transmitted. Among them, blood. First comes first is blood, then semen, then vaginal fluid, thereafter breast milk. Because breast milk to mother to child. So this is the mother to child transmission. MTCT, mother to child transmission, is also possible through breast milk, and other route also we'll discuss later. But mainly source of infection is because viral load is very high in blood, thereafter semen, thereafter vaginal fluid, thereafter breast milk. It is found in other source, but that is not conclusively shown as a transmit. So from other source of food, saliva, urine, then tears, that is not the source of infection. Okay, host factors. Agent we discussed, and the host. First agent is, so mainly this is the disease of productive age group. Mainly the SIV/AIDS or SIV positive found in 25 to 49 years of age group. So they are productive age group. They are independent age group. Mainly it affects 25 to 49 years of age group, and remaining other group are less common. But there is no age bar, but generally in other group except 25 to 49 years, the prevalence is very, very low. Also a diagram, then it will be clear. In terms of sex, high in male. Almost male female ratio is almost 1.8 is to 1. Male female ratio is 1 is to 8, or only 1.8 jati bhasa, 1.5 is to 1 jati bhasa, but previously it was 1.8 is to 1 थियो, male female. So it is high among male. So this is the diagram. You can see in the picture. So the prevalence of HIV is higher among 25 to 49 years of age group. In other age group, it is very low. Among 25 to 49 years, 12,641 male and 8,840 female. Similarly, 50 plus, 5,110 male, but 1,910 female. So this is the age and sex, age group and sex. So higher among male and higher among 25 to 49 years of age group. Okay, it is also associated with social factor, and it is also known as social disease, age tuberculosis. So this is also social factor or social disease. So it is also associated with other social factors such as prostitution. So that is mainly for earning money, for income. It may be easy money. So prostitution, but when we think prostitution, in our mind there is prostitution is female. There is female or girl prostitute. We don't think male prostitute, but you will be amazed after seeing other diagram. We will discuss in that slide. Broken homes. So there is two type of family generally. One is broken family, another is problem family. So first, what is problem family? If the basic needs, such as shelter, gas was simple, eta. So facility of eat, food, eta. Food, shelter, and cloth. So that is the basic need. If the basic need is not fulfilled, then the family is far below the standard or normal or average. So that is a problem family. That is the problem family. So they cannot meet the basic need of the life. So they are deprived from the food, cloth, and shelter. So that is the problem family, which is also associated with prostitution. Problem family is associated with prostitution or income generating source. That is the problem family. So what is the broken family? Broken family, again we can classify paternal separation, maternal separation, or dual separation. So in broken family, so there is separation from father. It may be death, it may be lived at home and get married with other girl or woman. So that is the paternal separation. Maternal separation So it may be death of mother, or mother left the home or married with another man. A dual separation, that is maternal and paternal separation. So in this condition, the children are deprived from the affection of the parent, and they may be indulged in the bad behavior or bad company or bad habit. So that is a broken homes. And sexual disharmony. Due to sexual disharmony, it may be male, it may be female, may source for another sexual partner for fulfilling their sexual desire. If there is sexual disharmony, there may be strained relationship between husband and wife. So fulfilling their desire, they can source another sexual partner. So that is a sexual disharmony. So that can create the extramarital affair. And poor socioeconomic status. To poor socioeconomic status, mainly it is described or measured by three parameters. That is the income, occupation, and education. If all are low, then they may be indulged into bad behavior or bad company. And return traffic woman or girl. So these are the social factors. And definition of HIV AIDS, mainly epidemic, HIV epidemic. So it is given by WHO and UNAIDS. So there are three terminology or three definition of HIV epidemic. So first, low level HIV epidemic. Low level HIV epidemic, that means the prevalence of HIV AIDS is low, simply. But in terms of definition, HIV prevalence has not consistently exceeded 5% in any defined subpopulation. In any defined subpopulation, if the prevalence of HIV/AIDS is not more than 5%, so that is the low level of HIV epidemic. So, what is subdefined population? We can we have to know. And subdefined population, that is synonym word is high risk group. So, what is high risk group? It may be men sex with men, MSM, PWID, people who inject drug. It may be sex worker, male sex worker, female sex worker, client of sex worker. So these are the high risk group. So low level of HIV epidemic in all high risk group or in defined subpopulation, if the HIV prevalence is not more than 5%, that is the low level HIV epidemic. That means there is not much big problem of HIV in that country. That is the low level HIV epidemic. Also diagram, by diagram. So this is the high risk group or sub-defined population, PWID, sex worker, client of sex worker, labor migrant also, either transport workers, MSM, man sex with man, partners of migrant or housewife. So they are the sub-defined population or high risk group. So I want to show this diagram, pie chart. If the in high risk group, if the prevalence is not more than 5%, so that is a general HIV epidemic. But in case of Nepal, the MSW, male sex worker prevalence is 6. If it is less than 5% or not more than 5%, so that is generalized HIV epidemic. But in context of Nepal, MSW, male sex worker prevalence is 6%. Female sex worker is only 1%. PWID, that means people who inject drug, right? Male 4%. Client of sex worker 6%. Again, MSM, male sex with men 9%. TG transgender 9%. So it is exceeded than 5%. That is the LR males, low risk male 37%, and woman 37%. 37. But they are not high risk group. LR, low risk male. But high risk group, MSM, high risk group, that is 9%. Client of sex worker 6%. Similarly, male sex worker 6%. So in this high risk group or defined subpopulation, if the prevalence is more than 5%, so that is not the generalized HIV epidemic. So that is called concentrated HIV epidemic. In subdefined population, if the prevalence of HIV is more population. So that is called concentrated HIV epidemic. Again, I come back to previous slide. So concentrated HIV epidemic. So Nepal is facing the problem of concentrated HIV epidemic, where the general population is prevalence is very low. That is, according to annual report 2074-75, its prevalence is 0.15. But the prevalence of HIV is higher than 5% in sub-defined population. So MSW 6%, PWW transgender 9%, so more than 5%. So definition of concentrated HIV epidemic is HIV prevalence is consistently over 5% in at least one defined subpopulation, but is below 1% in pregnant women in urban area. So Nepal is facing the concentrated HIV epidemic. The prevalence of HIV is only 0.15%, but in a sub-defined population, it is more than 5%. So that is a concentrated HIV epidemic. Nepal is facing same problem. Next is generalized HIV epidemic. Previously, low-level HIV epidemic, where the HIV prevalence is not more than 5% in any sub-defined population. In generalized HIV epidemic, HIV prevalence is consistently over 1% in pregnant women. If the prevalence of HIV is consistently over 1% in pregnant women, so that is called generalized HIV epidemic. Low level in sub-defined population, not more than 5%, more than 5%, but in pregnant women of the urban area, prevalence is less than 1%. That is the concentrated HIV epidemic. In generalized HIV epidemic, HIV prevalence is consistently over 1% in pregnant women. So this is the different three types of HIV epidemic given by WHO and UNAIDS. Okay, modes of transmission. So main is sexual contact, mainly heterogen. There is homogeneous or MSM. It may be men sex with men, or that is homo. Then next is hetero, different sex, heterosexual, homosexual, heterosexual. So mainly the disease is transmitted by heterosexual, male female. So that is the first sexual contact, that is the unprotected sex. It may be anal sex, it may be vaginal sex, it may be oral sex. If it is anal sex, it may be MSM or from heterosexual form. If there is anal sex, then the chance of transmission is high because there is tissue destruction or abrasion of the tissue of the receptive partner, but little bit safer in vaginal than anal. And the size of risk is affected by the numbers of factors, including presence of STD. If there is presence of STD, especially synchroid, syphilis, herpes, then the risk is 8 to 10 times high. If there is presence of STD, such as synchroid, syphilis, herpes, then the risk is 8 to 10 times greater. Next is sex and age of uninfected partner. Sex. So if we compare with male and female, the exposure part is larger among female. So exposure part is huge or larger among female. Obviously, the risk of transmission is higher among female than male. And another reason is the semen has greater viral concentration than vaginal fluid. So that is another reason. First is exposure part, second is viral load or viral concentration is high in semen than vaginal fluid. So that is two reasons. In terms of age, mainly adolescent girl and post-menopausal woman, their cervix is less efficient barrier for HIV. So risk is higher among or during adolescent and post-menopausal. So there is no protective effect or less efficient barrier for HIV. And the chance of transmission is higher during menstruation. So chance of transmission is higher during menstruation. So we cover sex and age, type of sexual act. We already discussed. If it is anal sex or oral sex, then vaginal sex. Right? In oral or vaginal anal sex, there is tissue destruction or abrasion of the receptive partner. Then the risk of transmission is higher in anal, especially anal. And the stage of illness. In stage of illness, it is more virulent during window period. In window period, so that is high risk for transmission. So first stage of window period, then in advanced stage, that is the virus is more virulent. Especially window period and the advanced stage, the risk of transmission is higher. Then the virulence of HIV strain, that is type 1 and type 2. Type 1 is more common and more virulent than type 2. So they are the sexual contact. Then next is setting of the contaminated injection equipment, tattooing, skin piercing tools, and surgical equipment. So through these tools, surgical equipment, it may be skin piercing tools, tattooing, injection equipment, needle syringe. From this route, also transmission is possible. Even if infected person using toothbrush and other person use same toothbrush, then from that route it may be transmitted. So through needle syringe or through surgical equipment or skin piercing tools, so it can be transmitted. So this is the second route, second mode. Then third one is through infected blood or blood product. So transmission of the HIV infected blood or blood product. So this is the third mode of transmission, through infected blood or blood product or transplantation of the organ. And fourth is from mother to child. In mother to child, the transmission from mother to child in different four stages, four phases. It may be during pregnancy, especially last week of the delivery, generally. It may transmit before that, possible, but mainly last week of the delivery. And if there is CS, then mother is using antiretroviral therapy, ART, then the chance of transmission is around 1% or less. If the mother is taking ART and that lady performs CS delivery, then the risk of transmission is 1% or less. Then it is also possible during labor and delivery. During labor and delivery, that is also possible to transmit. So during labor, during delivery, and through breastfeeding. So through breastfeeding, there is also possible. So it is also different within 6 months than after 6 months. So there is one fact attributable risk of mother to child transmission. So phase of pregnancy or duration of the breastfeeding. So during pregnancy, the risk of transmission is 5 to 10%. During pregnancy, risk of transmission is 5 to 10%. During delivery and labor and delivery, the risk of transmission is 10 to 20%. During breastfeeding, 5 to 20%. Overall, without breastfeeding. So, except breastfeeding, we can say during pregnancy, during labor, and during delivery, 15 to 30% is 15 to 30% is. So without breastfeeding during pregnancy, during labor and delivery, the risk of transmission is 15 to 30%. And overall with breastfeeding up to 6 months, 25 to 35%. So overall with breastfeeding to 6 months, 25 to 35%. And overall with breastfeeding to 18 to 24 months, the risk of transmission is 30 to 45%. So altogether, from pregnancy to breastfeeding up to 24 months, altogether the risk of transmission is 30 to 45%. Total risk of transmission is 30 to 45%. And according to WHO, the risk of transmission through breastfeeding is 13%, according to WHO. So this is presented by Nepal or Nepal government, DHS. And altogether, from pregnancy to delivery, the risk of pregnancy to delivery to breastfeeding up to 24 months, the risk of transmission is 30 to 45%. Okay, incubation period, it varies from 6 months to 10 years or even more. Generally 9.2 years, the virus can lie silent in the body for many years. So there may not be sign and symptom. And in window period, the after blood examination, it becomes negative in window period, and the person can transmit the disease from one to other. And after window period, there is seropositive. After window period, there is seropositive. If we check the blood, then it will be HIV positive, but there is absence of sign and symptom or clinical features. So it remains silent for many years. The percentage of people infected with HIV who will develop clinical disease remains uncertain. Possibly among 10 to 30% will develop AIDS. Another 25 to 30% will develop AIDS-related complex. So that's why it is uncertain. However, it is estimated that 75% of those infected with HIV will develop AIDS by the end of the 10 years. Among 75% of those who are infected will develop AIDS end of the 10 years. So this is the incubation period. So global and regional scenario. So this is the scenario given by WHO. This is a little bit old data. In 2015, 1.1 million people died from HIV-related cause globally, mainly due to OI, opportunistic infection. There were approximately 36.7 million people living with HIV at the end of 2015, with 2.1 million people becoming newly infected globally. So 36.7 million people are PL-HIV, people living with HIV, 36.7 million, and 2.1 million people are newly infected. Sub-Saharan Africa is the most affected region, with 25.6 million people living with HIV. So total 36.7 million PL-HIV, but 25.6 million people PL-HIV, which is found in Sub-Saharan Africa. Okay, let's start. It is that currently only 60% of people with HIV know their status. Only 60% know their status. Remaining 40% or over 14 million people need to access HIV testing service. So only 60% know their status. So remaining 40% are unknown about their status, whether they are negative or positive. And between 2000 and 2015, new HIV infection fell by 35%. AIDS death fell by 28%, with some 8 million lives saved. So this is the global report. And 6 countries accounted for 60% of global total. That is India, Indonesia, China, Nigeria, Pakistan, and South Africa. So these 6 countries accounted 60% of the global case. 60% covered by only 6 countries. The rate of progress in these countries will have major influence on whether or not the 2020 global milestone are achieved. And in case of Nepal, the male-female ratio is 1.8 to 1. 1.8 to 1. But this ratio is little bit decreased. Now it is around 1.5 is to 1. Okay, this is the scenario of Nepal. So first case was identified in 1988. Therefore, in 2007, the prevalence of HIV was 0.5%, and people living with HIV/AIDS was 70,000, and the annual death was 5,000, similar to tuberculosis. Because still 5 to 7,000 people are dying due to tuberculosis. But at that time, or before 13 years, the annual death was 5,000. Similarly, after 2 years in 2009, the prevalence rate was 0.4. It is little bit decrease. And the PL HIV was 64,000 and death was 4,700. All are decreasing in trend. Similarly, in 2010, its prevalence was 0.39. After 1 year, it was 0.33. In 2011, it was 0.33. In 2013, prevalence was 0.28. In 2014, prevalence was 0.23 in 2014. Similarly, in 2016, prevalence 0.17. It was 0.21 among male and 0.13 among female, and altogether our median prevalence rate was 0.17. So all are in decreasing trend. In 2017, so this is the latest data, prevalence is 0.15. Before 1 year, 0.17, but in 2017, the prevalence is 0.15. So at least we have to remember the prevalence of HIV, that is 0.15, 0.15 prevalence. For 1000, there is 0.15 prevalence, male 0.18 and female 0.12. So annual HIV infection. So that is by route of transmission from 1990 to 2020. So sex work, very little. Husband to wife, little more. Wife to husband, casual sex, male sex, needle sharing, and external infection. So this is the route of transmission. So annual HIV infection, route of transmission. Okay, this is the province-wise service statistics, HIV testing and counseling in 2074-75. Total positive reported case was 2,101. This is the reported case only. Reported case 2,101. The slight positivity L is 0.6%. So this is the reported case. But estimated case, estimated people living HIV/AIDS, that is 42,735, according to NCRC, National Center for AIDS and STD Control. Estimated PL/HIV is 42,735, male 20,332, female 12,503. And these are the subgroup: children, adult 15 to 45 years, 24,663, adult 50 plus 6,875, and the prevalence was 0.17 according to NCSC 2016, and HIV incidence per 1,000 0.03. Okay, this is the scenario of the HIV and AIDS. There is estimation of HIV burden. So this is the formula of estimation of HIV burden. B equal to P upon T into R. B equal to P upon T into R. B, that means total estimate of the burden of HIV, which we are going to test for estimation of the HIV burden. So how big is the problem? The problem may be big, the problem may be small. But Nepal has a facing concentrated epidemic problem where the high risk population or sub-defined population, the prevalence of HIV is more than 5%, but in pregnant lady of the urban area, the prevalence is less than 1%. So B equal to total estimate of the burden of HIV. P stands for number of HIV positive. The meaning of P is number of HIV positive, and T number of sample tested, and R estimate size of the population. So what is the sample size? For example, 10,000 is the sample size, and among 10,000, how many sample we collected? That is denoted by T. So how much sample we tested? That is T. For example, R is estimated sample size is 10,000. 10,000. Among them, we test 1,000. For example, we test 1,000. So that is the T. And among 1,000, the test result is positive around 10. Okay, 10 HIV positive, 1,000 is sample test is, and R, that is 10,000 is the estimated size of the population. So 10 upon 1,000 into 10,000. This is the example. So this is the estimation of HIV burden. Okay, clinical manifestation. First, initial infection with the virus and development of antibodies. So this is the initial infection. Initial infection with virus and development of antibodies. So initial infection that consists of window period as well as thereafter development of antibodies, that is the seropositive or HIV positive after blood sleep. Then asymptomatic carrier stage, ACS, asymptomatic carrier stage, there is no presence of the sign and symptom. There is AIDS related complex, ARC. Then last stage is AIDS. So this is the clinical manifestation, and the clinical manifestation may be different according to book, according to literature. So initial infection and development of antibodies. So most HIV infected people have no symptoms for first 5 years or so. So window period, that is 3 to 4 weeks, including or thereafter HIV may be positive, but the person has no symptoms for first 5 years or so. It is depending upon the nutrition status. If the malnourished, then maybe occur before that, and immunity power. So nutrition is prime importance. And the HIV antibodies usually take between 2 to 12 weeks or more to appear the bloodstream. So HIV antibody usually take between 2 to 12 weeks or more to appear in the bloodstream. So generally window period consists of 3 to 4 weeks mainly, but it may be range from 2 to 12 weeks. Maybe 2 to 12 weeks. So generally window period consider 3 to 4 weeks, but as long as 12 weeks. As long as 12 weeks, that means 3 months. It may be 3 months. So window period is long as 3 months. Then thereafter asymptomatic carrier state. Infected people have antibodies, that is seropositive or HIV positive, but no signal of the disease. There is no sign and symptom. It is unclear that how long the asymptomatic carrier state lasts. So that is the asymptomatic carrier state. Next is AIDS-related complex. In AIDS-related complex, there are major clinical manifestation of the AIDS. That is diarrhea lasting longer than 1 month. So diarrhea more lasting longer than 1 month. Then loss of more than 10% of the body weight. There is loss of body weight 10% or more. Other complex such as fatigue, malaise, oral thrush, generalized lymphadenopathy, and enlarged spleen. So generalized lymphadenopathy may be common. So there is enlargement of lymph node more than 1 centimeter in diameter, occur in 2 or more sites other than groin during the period of 3 months or more. So that is the generalized lymphadenopathy. So lymph nodes are larger than 1 centimeter in diameter, 2 or more sites other than groin, and the period of 3 months or more. So that is generalized lymphadenopathy. In its complex, mainly major classification or major clinical manifestation may be occur. Diarrhea more than 1 month, loss of body weight more than 10%, and diarrhea may be present. Okay, fever may be present. So diarrhea, loss of weight, and the fever is a major classification. And the other complex are fatigue, malaise, oral thrush, generalized lymphadenopathy, and enlarged spleen. So they are the AIDS-related complex. And last is AIDS. AIDS is the end stage of HIV infection. So advanced stage. So these are the infection. It may be tuberculosis, that is the OIs, opportunistic infection. Tuberculosis, herpes simplex, herpes zoster, hairy leukoplakia, Kaposi sarcoma. So there is reddish browny type of tumor which is seen in skin. In fungal infection, that is Candida esophagitis, cryptococcal meningitis. So in cryptococcal meningitis, there is fever, vomiting, neck, rigidity, may occur headache, vaginal candidiasis. So they are the fungal infection, then parasitic pneumonia infection, pneumocystic cardiac pneumonia. In pneumocystic cardiac pneumonia, so there is sign symptom of the pneumonia, such as cough, difficulty in breathing, shortness of the breath, maybe fever. So they are the clinical manifestation of pneumocystic cardiac pneumonia. So clinical features are similar to pneumonia: cough, there is fever, difficulty in breathing, or toxoplasma encephalitis. So such opportunistic infection may occur. Okay, WHO clinical staging. It is 9 o'clock. So 1 hour is finished. That's all for today. We will discuss WHO clinical staging prevention in next class. So I take another one class to finish. I 7 else. Okay, that's all for today. Thank you.
Thank you.
Thank you all.